Recording is
Hi, everybody. Welcome and thank you for taking some time out of your day to learn about the aging brain with us. So it is Dementia Action Week, and part of the program is to educate people on dementia to reduce the stigma and discrimination that's experienced by people living with dementia. Communities that do take action to become dementia friendly have less fear and a greater understanding of dementia, less stigma and discrimination, more support and better systems for people living with dementia. And so we're hoping with this seminar, we can help to educate and help to break down some of those barriers. Let me just get to the next screen. We've missed one. So before we get started, I would like to acknowledge the traditional custodians of the land we are meeting on today, wherever you may be, and pay my respects to their elders past and present. I extend that respect to Aboriginal and Torres Strait Islander people joining us today. So the plan for today is I'll share a bit about me, a bit about what we offer here at Empower. We'll go into a bit of an overview about how the brain changes as we age, which can lead to dementia and depression. We'll go through some of the early warning signs and what to look out for with your clients, the multidisciplinary approach and how we help these clients. We'll go into a bit about the connection between dementia and depression, and there will be time for questions at the end. The chat's disabled, so if you do have any questions, just pop them in the Q&A. We'll get around to them at the end of the seminar. All right. So a bit about me. My name's Liv and I'm a physiotherapist. I've been a physio for 7 years. I've been with Empower Healthcare for the past 2.5, and with Empower, I've worked full-time in the home care setting. So before that, I worked in a residential aged care. So I have had a fair bit of experience working with people with dementia. I do have a personal connection to dementia. So my grandma, about 3 years ago, had a really severe stroke, which left her with late stage dementia. Probably the hardest thing was seeing how that affected not only her, but my family. And I found that the education that I could provide for them as a healthcare professional helped them to manage that change and then to be able to interact with her and provide the best quality of life we could for her. It was hard for them to see that change, but the education did make a really big difference. So that's why I'm so passionate about educating people about dementia. It's to help them to break down barriers, and it enables people with dementia to live their best life. When I'm not a physio, I enjoy going to brunch. I do ballet regularly, and I'm always working towards an exam for that. I go to the gym occasionally. I have competed in fitness comps before. And that little sausage dog in the photo, that's Arnold. He's almost 4, and he is my baby. He's my world. So next one. So at Empower, we are an allied health team. We have physio, OT, nursing, massage, osteo, dietitian, speech, podiatry, and allied health. We all work very closely just to make sure we provide the best care for our clients, make sure it's a holistic approach and that we're not missing small aspects. It's also very important with dementia too, to make sure that all aspects are being addressed. So what is dementia? It's not a specific disease, dementia itself. It's actually an umbrella term that's used to describe a broad range of conditions. These conditions affect the cognitive function and how our brain works. The symptoms of dementia vary greatly. A lot of people know about the cognitive changes and the changes in memory and thinking, but there is also a lot of changes in physical capabilities, and some changes in cognition, such as memory or judgment, can affect physical aspects too. We'll go into it a bit as we go on, but it's important to remember that it's not just a cognitive condition. There's all aspects that do need to be addressed, and we can't forget those, because that person will then not be able to live their fullest life. There's 4 main types of dementia. Alzheimer's is the most common, affecting 60 to 80% of people. And this disease, it disrupts the brain's neurons, and you get a buildup of abnormal proteins in the brain. These proteins are called plaques and tangles. A decrease of these important chemicals, it stops the messages traveling through the brain correctly, and it affects how these people communicate with each other, with their family, friends. The next 3 most common, one is vascular dementia. This is the one that my grandma has got. So vascular dementia is when there is a lack of blood supply to a part of the brain. So this lack of blood supply causes the brain cells to die, which means that the brain cells can't function as they normally do. The signs and symptoms will vary greatly depending on which part of the brain has lost that blood supply. And this is usually caused by a stroke or a car accident or some event that has caused that lack of blood supply. It can be a gradual lack too, but it's usually caused by some significant event. It's really important to get medical management straight away with this, because this is one type that we can delay the progression through medical management. The next one is Lewy body disease, and that presents a lot like Parkinson's disease. It can be confused. The two can get confused. So there's tiny structures in the brain called Lewy bodies, and they develop in the cells, and it disrupts the messages in the brain. All of them are a disruption in the neurons in the brain. The last of the most common types is frontal temporal dementia. So this is when either the frontal lobe or temporal lobe of the brain are affected. The symptoms vary depending on the type of lobe. So the frontal lobe is responsible for behavior. So if the frontal lobe's affected, there'll be a change in someone's behavior, whereas the temporal lobe, there'll be a change in someone's language or communication. You can get affected in both, so it can affect both behavioral and communication. There's lots of other conditions. I think there's over 360 that can contribute to a diagnosis of dementia. Some of the other common ones are Parkinson's, multiple sclerosis, Down syndrome, so many more. Couldn't list them all. So we have to look out for, with our clients, just looking out for the early warning signs, because the earlier we can provide intervention, the better long-term results we're going to get for them. So it's important to look out for the differences between like a mild cognitive impairment or a diagnosis of dementia. So the symptoms we've listed here, for example, it's normal if you're occasionally forgetting appointments or a friend's birthday, but you remember later on, that can be a sign of mild cognitive impairment. But if someone's forgetting these more often and they're just not remembering them at all, can be more of a sign of dementia. Or it's normal to forget the day of the week. We all do for a moment, but you remember later on. But a person with dementia is going to have difficulty finding their way around a familiar place or feel confused in an environment that they wouldn't normally. They might forget how to get to the kitchen, how to get to the toilet, examples like that. So there is a difference between a mild cognitive decline and then dementia. If someone's showing signs of mild cognitive decline, that often will progress at some stage to dementia. So if we pick it up early, get them in to see a doctor, it'll have the best results for them. We've got some interesting statistics. So 1 in 10 people over the age of 65 have a diagnosis of dementia, whereas 3 in 10 over the age of 85 will have a diagnosis of dementia. Dementia is progressive, so you can start with a diagnosis and it'll get worsen, or someone at 65 might be showing those slight mild cognitive decline that then progresses into dementia, adding to this 3 out of 10 over the age of 85. Something I find really interesting is dementia is the second leading cause of death. So it's secondary only to coronary heart disease. In women, it is the number 1 cause of death. So it can be a bit confusing. How does dementia, a cognitive condition, cause so much death? The dementia itself doesn't cause death. It's the deficits that can lead to events that would otherwise have been avoided if the person didn't have dementia. Yeah, it's a bit confusing, but for example, like accidents and incidents is one of the causes of death. Someone's with dementia, their mobility, stability, and spatial awareness can be affected, which can lead to a fall, and a severe fall can lead to death, or poor management of the results of that fall can then lead to death too. And if it's determined to be dementia was the cause, it would suggest that that person wouldn't have fallen if they didn't have dementia. They wouldn't have lacked that insight and they could have avoided whatever caused the fall. Food and frailty. People with dementia have difficulty preparing meals. They often have food avoidance. It can be difficult for them to swallow. They stop eating. They become frail and without the nourishment. They become weak, risk of falls, infections. And same with the others, aspiration and infections. They have trouble swallowing. Food goes down the wrong way. They get an infection in their lungs, which can cause death. Not all the time, but in the worst cases, it can. Coexisting illnesses. If someone's got with dementia has, say, a tiny scratch on their leg, someone without dementia will know to keep that clean and seek the proper treatment. Someone with dementia might not even know they've got that scratch. It can get infected, and something that otherwise would have been minor can cause death or severe illness. Continence and self-care. It can be hard for them to get to the toilet. They can slip, have a fall. And skin ulcers, again, people with dementia will withdraw and they can become immobile, leading to pressure areas that need to be managed. Late stages of Alzheimer's, all bodily functions sort of decline and the lungs, kidneys give way. So that can cause death too. A bit morbid, but it's just important to know that we have to treat as early as we can to avoid it from getting to that stage. So that comes into the allied health and how we can help to treat and manage these people. Nurses, they can do a cognitive assessment to work out the main deficits in these people, which can help us know which services we need to introduce. They're good with medication management. People with dementia can forget to take their medication. Nurses can assist with this. And general health, infections, nurses are the people we want involved. And as I mentioned before, infections are a big problem with dementia. Physios, that's where I come in, physios and osteos. People with dementia, yeah, they withdraw, they become weak, they become immobile. And physios, we can help to build that strength. We can help to overcome those barriers. This will help them be more involved in the community. We can do it individual or there's group exercises within the community. And pain management's a big thing. People with dementia often lose their ability to communicate. So sometimes pain goes unnoticed. So physios and massage therapy can really help with pain management. OTs, again, great with cognitive and functional assessments. They can provide home modifications or equipment that can make it easier for this person to live within their home or to access the community. Speech pathologists, I mentioned before that people with dementia often lose or have a reduced ability to swallow, to eat. That's where a speech pathologist can come in. Helps with communication strategies if someone's having trouble with that. And dietitians can help come up with a meal plan that's going to invite that person in and they're going to enjoy eating. So that will help to reduce the risk of malnourishment. Yeah, it's all intertwined. Everyone sort of works together. And even with the eating, OTs can help. They can provide strategies, modified cutlery or other strategies to help people eat better. All interrelated. So I'd like to introduce you to a client I've been seeing and how we have managed her over the past I've been seeing her for about a year. So she's a lovely lady who was diagnosed with Alzheimer's about 7 years ago. Prior to this, she lived a very active lifestyle. She used to run marathons, started doing that in her 40s. And her husband is now her main carer. And he has struggled to see his lively wife who used to run marathons now be a hoist transfer. It's hard to shower her. She's been coughing a bit. She's had trouble eating. She's nonverbal, so it's hard for him to work out what she needs when she needs it. So we've needed to introduce nearly most of the multidisciplinary team. So when she started needing a hoist transfer, an occupational therapist did an assessment and prescribed the hoist. Also, a wheelchair for accessing the community. To do this, they had to add ramps at the front entrance. And the massage therapy was needed because she was immobile and she was becoming really contracted. She wasn't able to stretch her arms. The massage therapy helped to release those muscles a bit, as did I with physio. And these contractures and this inability to walk led to difficulty showering. With these contractures, her arms were sort of stuck like this. You couldn't lift her arms to clean under in her armpits or in her elbows. So we had to work with physio and massage to help to prevent further contracture and to reduce the current contractures she had. She needs a PCA to help with the showering because her husband can't do that on his own. Occupational therapist has provided equipment for the showering. Again, massage therapy for pain and for those contractures. He mentioned a few weeks ago that she was coughing a lot, and then she was admitted 3 times to hospital with aspiration pneumonia. She was seen by a speech pathologist who determined that her swallowing function had declined. This speech pathologist recommended she be put on a modified, thickened and pureed diet. Again, big change for her husband too, to try and work all of that out. And the dietitian has also made sure that with that new diet, she is still getting all the nutrients that she needs. And then again, we needed the nurse when she came back from hospital just to make sure everything was okay. The infection was under control. So yeah, it's a very complex management plan we have going on, but it's not something I could do by myself. And I've had to ask a lot of different disciplines to lend a hand. She was getting rotten teeth. She's had to have her teeth pulled out. So we needed a dentist for that. That was also causing a difficulty with eating. And then she's got her geriatrician and her psychologist and neurologist. It's a big team, but it's needed so that she can live her best life. We've been walking outdoors with a gutter frame with 2 assist. It can only be done with a 2 assist and with me, so it doesn't translate functionally at home, but there is the benefits of weight bearing through her joints, preventing those contractures, strengthening, and it helps with the showering too. So big care team, but together it's made a big difference. And she's been able to stay home with her husband. We've also had to look at support networks for him too. And there's a lot online. There's a lot of helplines I'll mention later on. So there has been a correlation found with dementia and depression that also has to be balanced and managed. So as we age, certain parts of the brain can shrink, especially the important ones that are for learning and complex cognitive tasks. The communication between the neurons, as I mentioned before, is disrupted, and that affects different parts of the brain, causing different symptoms. The blood flow can decrease, whether it's from an incident like a stroke or gradual over time, and that again causes disruption to the signals in the brain. And inflammatory processes have been found to have a negative impact on the brain and the signals that are transmitted. As we get older, we get more inflammatory markers through our body, so that contributes to the disruption in the brain. This can cause dementia, but these changes also are found to cause depression. So that's the link. So 20 to 30% of people living with dementia also have depression symptoms, and up to 40% of people living with Alzheimer's suffer from significant depression. So people with dementia often develop depression symptoms as the same processes mentioned before that result in impaired cognition in dementia also cause depression. So they can come hand in hand, not always. When early dementia symptoms do arise, they can then lead to depression. So it's the chemical causes in the brain, as well as confusion that these people experience. They get confused, they withdraw, they don't access the community as much because they get lost, can't find their way, or it's overwhelming because they don't know what's going on. They withdraw and become sort of recluse and live at home where they're not going to experience that stigma or that feeling of loss of control. When you become recluse and withdraw within yourself, it can lead to depression. So that's how that sort of cycle works. There's also the change in attitudes from family and friends. Dementia is a hard condition to understand, and to see someone you knew changing into someone you don't know can be hard. And that sort of bias can, it changes your relationships with that person. And then that can cause that person to again become withdrawn because their friends sort of don't know how to react with them. So their friends sort of distance themselves. That's why this education is so important. If people can understand dementia, they know how to interact with their friends and family. And that has a big part in someone's mental health. So the link between dementia and depression, we've sort of gone through it, but a study conducted in 2022, August, so not that long ago, just about a year, found that depression is a significant risk factor for cognitive decline. So the review showed that depression and a number of its precursors, specifically the active pro-inflammatory mediators, so that inflammation in the brain, it leads to the vessels in the brain dying. So that then causes dementia. Again, it's a cycle. So signs of depression are very similar to that of dementia. So it's a loss of interest in activities, lack of energy, withdrawing, and change in personality too. So increased agitation or confusion. So it can be hard to differentiate the two. But that again just shows how interrelated they can be. here's sort of that cycle. So common to dementia and depression is a low mood, poor sleep, social changes, changes in diet, and they sort of feed into each other. So if you get a low mood, you're withdrawing, your brain's not as stimulated, parts of the brain can die, leading to dementia. It's a big cycle. But to help break that cycle is so to find that purpose and to help someone be able to fulfill that purpose. And here I mentioned before about the support networks that we needed for my client's husband. So the ways we can help someone with dementia is there's the medical side of it. So it's having a medical team, usually a geriatrician, there's usually a neurologist and psychiatrist, psychologist, as well as the allied health. So if we get proper medication management, we exercise and keep the people physically able to participate in activities, they can access the community, lifestyle modifications, and a healthy diet. And another one I've put in here is respite, which can be good to help the person that's living with dementia, but also their carers and family, such as my client's husband. Sometimes these people need a break. It can be hard to help someone living with dementia. So sometimes they just need some time to reset and to spend time with themselves. Even just time to go shopping, you know, like my husband can't leave his wife alone. So he has respite care to come and look after her for 3 hours a week. He uses that time just to get his hair cut, do the shopping, and just those things he needs to do for himself. And then there's a lot of support networks out there. I've mentioned a few. They're pretty easily accessible. You can Google them. There's a lot of helplines, a lot of information out there, and that can be really helpful for people that are living with dementia and the people that are helping them. Education is key. If you understand the condition, it makes it a bit easier to manage it. So these websites or these associations have got some very sort of simplified education that can really help. They've got strategies to work with the different behavioural deficits that we see in dementia. And that's the end of the presentation. So basically, dementia's not a disease itself. It's an umbrella term used for a lot of cognitive conditions. It affects not just the mental side of things, but also physical, social. Dementia and depression are both interrelated and have to be addressed. And it takes a very complex management team to make sure these people can live their best lives. And support and education are what are going to empower these people and the people caring for them. Have we got any questions? No, feel free to ask if you've got any. Hopefully I can answer them. Yeah, just put them in the Q&A if you've got any. Yeah, I agree with Kim. We just need so much more education and awareness so that these people can live their best lives. Stigma plays such a big role in so many things, especially dementia. Yeah. So if you do want to learn a bit more about dementia, we are offering a more in-depth education session run by physio. We haven't got a date for it yet, but if you are interested, just reach out to your state relationship manager and they can put your name down. Yeah, it'll just be a bit more in depth from what I've briefly covered today. The next webinar is falls prevention, very important. If you would like to join, you can scan to register or again, reach out to your state's relationship manager. It's all on the website. So you can check it out there. Very important topic. We are available on most social media platforms. We do have a website that has most of the information you'll need. If you do want to know wait list times, you can put a request form through and we'll send through the current wait times, the referral forms on there, and the rates. So the rates will be, you can send in a request and we'll send through the current rates for all of our services. This is our coverage. So we're in Vic, Queensland, WA, New South Wales. There's varying coverage in the states, but you can check it all out on the website. Go to the About Us section and service coverage, it'll be there. My references, and I'll just check the Q&A. Yeah, so people can have like lucid phases, and it can be sort of an up and down thing with dementia. And again, it depends on the management at times. Yeah, different types of dementia can require different types of physio. Again, it depends on what their deficits are and which part of the brain's affected. But as a general thing, most people with dementia do have a generalized functional decline, just from that withdrawal and from that lack of access in community and that lack of incidental exercise. So generally, we help with all dementia, but there is more specific physio that's needed dependent on the types. We do go into that a little bit more too in the more in-depth seminar. NDIS, does it cover dementia? That's a good question. I think it does, but usually someone under the age of 65 with dementia will have other comorbidities that are probably more so supported by NDIS. Oh, it's jumped. I've lost my spot. Where were we? Yes, respite can be so hard to get organised, and that is something that we all struggle with, is that it's so hard to access because it is such a needed resource. Yes, yeah, they do have that lucid phase, and that can also again be hard for family and carers too, because they get that glimpse of the old person they used to know, and then they have to relive that change again almost. But that is normal. Yes, they do have sort of ups and downs. Yes, it can be hard to diagnose with other genetic conditions. They can run blood tests and things. It's sort of a differential diagnosis to rule out other causes. So there's no blood test for dementia, but you can rule out the other conditions, and that will come to a medical team. A GP will run those tests. When someone asks the same thing over and over, how do we help them? Again, that is we go a bit more into depth with that in the other seminar, but it's sort of, there's a moral dilemma of, do you live in their reality or do you try and bring them back to the actual reality? I find I try and correct them, but if it's not landing, it's not going to. So sometimes it's easier to live with them. I had a client whose wife died 3 months prior. We'd be in a session and he'd ask, when is she coming back from the shops? It was that dilemma. Do we say she's actually not at the shops, she's passed away? Or do we say, I'm not sure when she'll be back? We tried she's passed away. It just meant he was reliving finding out that his wife had died. It was of no benefit to him at the time. In 20 minutes time, he'd forget that and ask where she was. So we used I'm not sure when she'll be back. I think she's just gone to get some bread. It's a moral dilemma. I try to correct or try to bring to our reality. If it's not working, it causes that person more stress. Sometimes it's better to just live in their reality. I hope that answered your question. thanks, Sophie. I try to do my best providing good service. We all do. We just want the best for the clients. Yeah. Reducing mild cognitive impairment, I would say, is just stimulation, finding a purpose, helping someone engage in what they love doing. If they love playing golf, how can we help them do that? It's keeping people stimulated and trying to prevent that withdrawal. Exercise groups specific for dementia, not that I know of. Dementia clients can usually attend just your standard group exercise classes, depending on the level they're at. Early stages dementia, they can usually attend those. If they're late stages, they're probably going to need more individualized treatment anyway. But I'm not 100% sure on that. I have not come across any dementia specific exercise groups. Yeah, respite, so important. A dance group in Brisbane. Yeah, that's so good. There actually is evidence that people who dance, so like ballet dancing or any other dancing, have a less likelihood of getting dementia. And that's because of that cognitive stimulation as well as the physical involvement too. Yeah, Dance Health Alliance. Yeah, so dancing has been shown to reduce risk of getting dementia. I hope I answered everything. Yeah, I don't know how to do hands up. We've got a couple of people with hands up. We'll see if we can let you talk. We can work it out. I've got Nicole on the side trying to sort it out for me. Or if it's a question, if you pop it in the Q&A, I can maybe... Do I see improvements in my patients? Yes. So I've seen patients that can go from needing assistance to transferring independently or to being able to access the community. The cognitive side of things doesn't often progress so much, but you can slow the progression. The physical side of things you can change, and it's having those supports. The eating, you can change that. So the disease causing the dementia is a slow progression, but the symptoms that it causes can be helped, if that makes sense. Hope that makes sense. Yeah. Hope that answers everything. All right. Well, thank you, everyone. Yeah, if you're interested in the more in-depth session, just reach out. You can access us through email, the website, if you've got any feedback or anything. Thank you for spending your time to learn a bit more about dementia. Hopefully it's provided some information for you that you can take away. And yeah, we just got to continue breaking down those barriers, educating people, and yeah, reducing that stigma is the main thing. All right. Thanks, everyone.